for this particular webinar. I've learned a huge amount, and it's been really good fun, and the interaction between the panelists tonight has been outstanding, so I'm sure you're going to have a good evening. Just before we get going with introductions, a quick bit of housekeeping from me. We've got some other great content coming up in the next couple of weeks. The next big webinar that we have is on trauma resuscitation. My good friend and colleague Ash Vazi Reddy from the Major Trauma Center at King's is going to be hosting a really interesting and diverse but really super experienced panel to talk about the various aspects of trauma resuscitation and their experiences of things such as the hospital emergency helicopter service, which they all contribute to. We've also got some of our orthopedic decision-making videos for you to catch up on. The second edition with Pete Bates and Alex Trompeter is currently out, and they're talking about how to fix, or the controversies regarding Schatzker 2 fractures of the proximal tibia. And you can catch up on all of that via the website or via YouTube. The final bit of housekeeping really before intros is just to remind everybody that OrthoHub has always been committed to bringing people really high quality educational content for free. We don't ask for subscriptions, and we don't ask you guys to pay, but we are committed to doing the best that we can to deliver something that's really high yield. So in order to keep us going and to keep Cash Actar in microphones, we have sponsors, and these sponsors help us to just keep it ticking over and to help keep our project moving forward for the benefit of the community. And I'm really proud to announce that Johnson & Johnson DePuy Synthes are our sponsor for this. And through their collaboration and their support, we can continue to bring you stuff like this for free. So thank you to them for sponsoring this event. So on to intros, and our host for this evening is Mike Reed. Now, when I was trying to think of how to introduce Mike, I was about to start to list all of his achievements. And I thought that actually, if I started down the long list and just read it all out, it might embarrass him somewhat. So that's exactly what I'm going to do. Mike is firstly a nationally well-known and highly regarded figure in the field of hip surgery. He was previously an ABC fellow. He is a previous co-author of the orthopaedic curriculum. He is, or has been, the chair of the educational committee of the British Orthopaedic Association. He was the national program director of the year a couple of years back, and he is on the steering committee of the National Joint Registry. He has worked on national collaborative studies looking at hip fracture care and enhanced recovery. He's still really involved in basic science research, and he's the chief investigator on a couple of massive trials, that some of which we're going to talk about this evening. So he is a really super accomplished individual and educationalist, and we are delighted that he and the rest of the panel have given up their time for us tonight. So Mike, thank you for being our host. I'm going to hand over to you for the rest of the evening.
Raman, thank you. That's quite an introduction. I'm very grateful. I'm a hip surgeon and a trauma surgeon, but today we've gathered three real experts to help us make some key decisions around hip replacement for trauma. So in the UK, we've got two great registries that track hip replacements being performed for trauma. Firstly, the National Joint Registry, and also the National Hip Fracture Database. Both of these show a gradual increase in hip replacements being performed for trauma until the end of 2019. The peak was at around 35% of those actually eligible for hip replacement, according to our national guidance. But after December 19, it began to drop off, and we've seen a steady decline, and that predates the pandemic. So our panel tonight might have some thoughts on why that activity is tailing off, and if we're falling out of love with trauma hip replacements. So we have a great panel for you this evening. We've got three very experienced panel members. Firstly, we've got Professor Matt Costa, who is in Oxford and is a giant of clinical trials and is the architect of the World Hip Trauma Evaluation Trials, which we affectionately shorten as WHITE trials. And he's now planning WHITE 11 or 12, and he's made a huge contribution to the literature, and perhaps more particularly to the daily management of how we manage hip fracture, because his trials are all very pragmatic and relevant. So after Matt, we'll be hearing from Murty, who is head of trauma in Northumbria, which is a large trauma unit in the north of England. He's actually my go-to surgeon for advice, and particularly when a treatment is not progressing well. So he has got a wealth of experience dealing with complex cases and maybe my complications. And he will be discussing some of the alternatives to hip replacement. And then finally, our third panelist, who's backed by popular demand, is Sam Hook, who is a busy hip surgeon and trauma surgeon in Portsmouth, which is in the south of England. You may remember she gave a very crystal clear account of how to do a perfect hip replacement in that rather excellent May Ortho Hub webinar on the perfect hip replacement. So along the way, we'll be discussing many aspects of hip replacement for trauma, relating to preparation, implant choice, the results of the various implant choices, and also the impact on patients. So the most experienced member of this group is, in fact, of course, the audience. And they're watching live from around the world. It's really vital that we receive your comments, and I'm glad that we've already received one in the Q&A, but please, we want as many questions to the panel so we can get them warmed up and hopefully well out of their comfort zone. So first of all, we have Matt Costa, and Matt is in Oxford. So Matt, if you're able to turn your camera on and share your slides, and tell us how the weather has been in Oxford today.
Yeah, pretty glorious. Got my shoulders burnt today, Mike, but it's now just starting to rain, so can't have it all.
Right. I thought you were just embarrassed, but nice to see you.
Thanks, Mike, and thanks for inviting me. Great. Can you see my slides there?
Yes, perfect.
Awesome. See if I make that a bit bigger. Great. So I'm just going to set the scene a little bit before Sam and Murty take over with some clinical casing. Just talk a bit about some sort of evidence. So firstly, why is this important? So this is the only figure in my my talk, so bear with me on this. So some of you will have seen this before, others perhaps less so. So this is just a figure showing what happens in recovery after hip fracture. So the horizontal axis here, the x-axis, is time, the first year after the hip fracture. And on the vertical axis is health-related quality of life. And this we measured using a tool called the EuroQual, which again, some people will be familiar with. And it's a general health-related quality of life tool. The scale for this utility score, this health-related quality of life tool, goes from about -0.5 up to 1. And it's anchored at 0, which is a health state equivalent to being dead, up to 1, which is perfect health. So that moment when you're running along the beach, age 18, and nothing can hold you back. So that gives you an idea of what we're dealing with here on that vertical axis. So the first dot on here is what happens, what patients report to us pre-injury for those patients with hip fracture. So as everyone in this audience knows, this just makes the point that patients don't have a health-related quality of life of 1 before their injury. It's actually only around just under 0.6, so only 60% of maximum health-related quality of life. This is a frail, older group of patients before they have their injury. Immediately after their injury, their health-related quality of life is officially worse than being dead. And you might think, well, that makes no sense. How can it be worse than dead? But if you're in the worst pain you've ever had, and you can't move and you can't look after yourself, and you're frightened to death, if that was a permanent state of health, how many of us would want to live like that? So actually, in this context, with this particular injury, it does make some sense. Now, of course, there's recovery, and the recovery is quite rapid over the first 30 days or so, up to around 0.3 at 30 days. And then there's a slow recovery out to about 120 days, but nowhere near back to anything like normal. And then interestingly, what you get at 120 days is as good as it can get, because there afterwards, there's actually an age-related deterioration in quality of life. So we've got a very short window to improve these patients' quality of life. So why am I starting with this graph? Well, it really just makes the point that after this hip fracture, patients lose around 20% of their total quality of life permanently. So just to put that into context, that's equivalent to having a stroke or a diagnosis of Parkinson's. So a massive impact on quality of life that I think previously was under-recognised for this important group of patients. So anything we can do to improve their quality of life, we need to take full advantage of it. Now, the other big factor, and the reason why we're talking about this, is cost. So actually 1.4% of total health and social care expenditure is spent on patients with hip fracture. That's over £2 billion a year. And although the NHS spend, the healthcare service spend is enormous, the social care bill's even greater. So if we can get patients more mobile, more independent, more able to look after themselves, this actually will not only benefit the patients, but also benefit society by reducing costs. So what about total hip replacement for hip fracture? Well, the evidence was synthesized back in 2011 and updated in 2017 by the National Institute of Clinical Excellence in the UK. Many of you will be familiar with this organisation. It produces guidelines across all of medicine and beyond into social care now. And it really dictates practice and indeed payments to healthcare clinicians in the UK, and increasingly influences healthcare systems around the world as well. So, as you will all know, hemiarthroplasty was traditionally the standard for surgical option for displaced intracapsular fractures. So what did NICE say about the role of total hip replacement after reviewing all the evidence from all around the world? So it basically set quite a low bar. If you were walking independently out of doors and you were fit from an anaesthetic and not cognitively impaired, you were basically eligible for a total hip replacement. So did anyone take any notice of this? This is some work that Dan Perry and some of my colleagues in Oxford did 3 or 4 years ago now. And they basically looked at the use of total hip replacement using hip fracture databases, HES and NHFD from the UK. And what they found was that only around 30%, as Mike said earlier, of patients who were eligible for a total hip replacement according to the NICE guidance actually received a total hip replacement. The other 70% did not. They mostly got hemiarthroplasty. And interestingly, 40% of patients who did get a total hip did not tick the eligibility criteria according to NICE. So what's going on? Well, the trend over time is gradually to be increased, but actually this has just started to level off now, and it's still only around 35% of patients around the country that are actually getting a total hip. And you can look for your own hospital, as ever, on free of charge on the National Hip Fracture Database in real time to see what proportion of your patients are getting a total hip. And the data tells us, when we looked into details around each hospital, the variation is absolutely enormous. So in some centres, around 60–70% of patients who are eligible for a total hip, according to the NICE guidance, were getting one. But in other hospitals, basically no one was. Not one patient was getting a total hip replacement. So colleagues of mine at University of Warwick asked the question, why? Why were the surgeons not taking advice? And this is what the surgeons told us from a series of in-depth qualitative interviews. They basically recognised the potential benefits of THR in selected patients in terms of functional recovery from their hip intervention. But many of the surgeons were not confident to perform that procedure themselves. They either didn't feel trained in it or were practicing another area of orthopaedics that didn't involve routine total hip replacement. But the biggest factor was that even if they did perform total hip replacement, and even if they did recognise the benefits in terms of function that we all believed in, they were still reserving total hip replacement for patients who were younger and who walked outdoors unaided. So not just walking outdoors, but walking outdoors unaided. So setting a higher bar than NICE recommended. So what's happened since then? What's the latest evidence? Well, there's been a lot written lately, but one study has dominated the literature, and that's the health trial, which is a multinational, great big trial of patients led by the team from McMaster University in Canada. And they randomised nearly 1,500 patients over 50 to either have a hemi or a total hip replacement for displaced intracapsular fracture. And the primary outcome measure was actually further surgery within the first 2 years, which is an interesting choice of outcome measure, and more about that in a second. What they really found was that initially in the first year, the further surgery was actually higher in the total hip replacement group than in the hemiarthroplasty group. Survival was lower in that group. But by 2 years, that difference had disappeared. They were about the same. And most of the early revisions, most of the early further surgery for dislocation in the total hip replacement group, as you might imagine, but other things started to go wrong with hemiarthroplasty after that first year. So the summary is that around 8% of both groups ended up having further surgery within the first 2 years, which is actually quite high when you think about that. And because the trial was quite large, they could say with reasonable precision that there was no difference, no statistically significant difference between the two in terms of the number of further surgeries. Interestingly, the secondary outcome measures did include some functional outcomes, and although there was a small difference in favour of total hip replacement, it was certainly less than previously reported. In this case, they used a WOMAC score, and this marginally favoured the total hip replacement group. So how do we interpret this? Well, it became clear that the choice of primary outcome measure was very interesting when reading the details about this trial, given that the rationale for total hip replacement was actually improved function in the previous trials, and the reason for the NICE guidance was based on improved function with a total hip rather than a hemiarthroplasty after a displaced intercapsular fracture. Other things to note were that the further follow-up for further surgery was only for the first 2 years. As you can see, or as you've heard, there was no difference between the two groups, hemiarthroplasty versus total hip at 2 years. But what about later on? Will acetabular wear be an issue, particularly in those younger patients with higher functional demands? And the follow-up at 5 and 10 years is going to be very interesting to inform this debate. Participants had to be able to ambulate without the assistance of another person, and actually 80% of the patients were over 70 years of age. So although the trial included patients of 50 or over, the great majority of patients included in the study who were randomized were actually in that older group, where we've already found out that surgeons in the UK aren't offering total hip replacement to that group. So there's no doubt that a health trial provides the stronger evidence we have to date and probably will ever have, that there's no difference in the risk of further surgery at 2 years, but the longer follow-up will be interesting. And health shows us also fairly clearly and fairly definitively, to my mind, that the previously reported benefits of total hip replacement in terms of function, hip function in particular, were probably not as great as the previous studies suggested to us. And there's no doubt at all that NICE will take this into account when they revise their next guidelines in a year or two. So how does this change my practice? What does this mean for me, and how might it inform your practice? Well, it certainly has changed my practice. In fact, it's changed my mind, really, because I was a big proponent of total hip replacement being offered to, quite a large number of patients with a displaced intercapsular fracture. But I've gone back on that, and I'm now only really reserving total hip replacement for that younger group of patients, and I'm recommending hemiarthroplasty to the great majority of patients with a displaced intercapsular. So who do I offer a total hip replacement to? Well, it's not really based on chronological age, it's based on activity levels. So I had an 85-year-old patient who came in the other day after falling off their push bike, and he got total hip. And the reason why? Because it turned out he was cycling 100 miles every week, and that's a hell of a lot more than I can manage. So he definitely earned his total hip replacement. So it's really about that higher end physical activity levels with some descriptions here. And they're the patients I'm reserving total hip replacement for these days. So thank you very much. That's all I'm going to say on this. There's an awful lot of literature in this area, but I think the two big things you need to know about, the NICE guidance and the health trial, and that's what will inform the debate over the next few years, I'm sure. Thanks, Mike.
Right. Okay, so we're just waiting for my video to be allowed back on. So Matt, I think you summarized that really, really nicely. And I must say that the more times I read the health trial, in a way, the less comfortable I am with it. And I think it's exactly, you've summarized the talking points in it. I mean, we've just done a 10-year review of our hemiarthroplasties and the revision rate. And half of them were revised in that first 2-year period that were in the health trial. But the other half of the revisions were done in years 3 to 10. And that would have obviously doubled the revision rate and would have made the data look very different. So I think that's the first point. And the second point really is about function. And you've said that really well. And I was, somewhat concerned when I read that we were throwing it out perhaps unnecessarily, because I think many patients probably would still benefit in terms of function. So my question to you is that if you were a clinical trialist, which you are, how would you, what would you use as the endpoint in that study? Because the study that was done, the health trial, is very, very similar size to the trials you run. The same sort of numbers as it happens. So you presumably could use the endpoints that you currently use, which is EQ5D. What do you think?
Yeah. So I was really surprised. I mean, I talked to the lead investigator on this was Mo Bandari, who is a world famous, very, very well established trialist, and so he knows what he's doing. But I was amazed when talking to Mo about why they chose further surgery as the primary outcome measure for exactly those reasons, Mike, because the rationale for using the total hip wasn't really about further surgery. It was about better function for patients. And as you say, with those numbers, they could actually have adequately powered a trial to look at hip function in particular. Interestingly, although I've often banged on about health-related quality of life being a really important outcome in this group of patients, because fundamentally that's what the patients told us that was most important to them. How long they lived and, you know, individual hip pain and so on was less important than their general quality of life. So that's why we've often used it as a primary. But in this younger, fitter group of patients, there is a risk of a ceiling effect, and there are other issues with using EQ5D as a primary, and hip scores in that very selective younger group are probably the best bet. Interestingly, the hip score that actually had the best validation data for hip fracture, despite being an arthritis score, was the Oxford score. So if I was powering that study myself, I probably would have done it on an Oxford hip score. We did, as you can imagine, write a protocol for that, but funny enough, given that health had already got that before us, we put that on the back burner because we thought they'd answered the question.
God, that damn Mo Bandari. Yeah,
he knows what he's talking about, Matt.
He does. In fact, there's an excellent Ortho Hub episode, if you like, on Spotify with Mo Bandari, which is absolutely fascinating. So I don't know if our other faculty want to turn their cameras on.
Can't seem to be able to, Mike. We cannot start the camera for some reason.
Okay, we will sort that out.
Right. Okay, yeah, start my video. Okay.
Does anyone have any questions for Matt on his talk there?
So Matt, I'm going to push you. So we don't think the WOMAC is a very good score for finding out the function. Oxford is better. We do not think that the endpoint was good, what they measured in the health trial. And number two, the number of hemiarthroplasty that is used commonly in UK in that particular trial are low. Most of them are bipolar. And I have heard one thing that is said about bipolar. And I'll come to that later. And then most of the patients, like you said, above 70. So how can we extrapolate it to our population? And how can we use that to inform us that the hemiarthroplasty that Mo is talking about in his paper is same as the hemiarthroplasty that we do and the scores we do? That's my criticism about and it started in 2009 and finished in 2017 at about 8 years. And it would have been nice to know what happened to those hemiarthroplasty at 8 years. And their follow-up, loss to follow-up was about 20%, 15 to 20%. And they do discuss that in the paper, saying that the way they have explained it, that it may not be important. But overall, there are some serious flaws in this paper as far as our population is concerned, is what I believe.
Sure. So, yeah, I mean, several points on there. So I think the choice of, I mean, it's always very easy to pick holes in papers. You know, some of us take great delight in it. I do it myself. But actually, this is 1,500 patients randomized in a multinational trial. This is a pretty serious piece of work, and it took a long time, but it adds to the literature. Now, although I said that the Oxford score is the best validated hip score in the context of hip fracture, then it doesn't mean the WOMAC's terrible. So I think the WOMAC's a reasonable score to use in this patient group, that higher functioning group of patients. And it shows pretty clearly that there's very little difference. The difference that is there is probably clinically unimportant for this group of patients. So I think this is pretty powerful evidence that the benefits in terms of hip function that we thought came from total hip across the board aren't there. Your point about the age group is very important, though, because they were older patients in this trial. And that's the reason why, rather than throwing the baby out with the bathwater, I'm not saying never use a total hip replacement. I'm just saying, in my practice, I reserve it now for that higher functioning group of patients who probably didn't get into the health trial. And then finally, about the choice of hemiarthroplasty, well, that's an interesting one. But as you know, the evidence that there's a difference between different types of hemiarthroplasty is pretty tenuous. And Mike and I actually, a few years back with Alex Sims, wrote up a trial of another 1,000 patients where we randomized between a Thompson's, you know, the cheapest implant you can get, cemented Thompson's versus an all singing, all dancing modular stem. And we thought there'd be a benefit to that modularity, that ability to increase offset or reduce offset or change length and so on. And we couldn't find a difference for that group of patients having a hemiarthroplasty. So I think we've got to be careful about extrapolating some of the historical data on differences between hemiarthroplasties. In this patient group, particularly older, lower demand patients, a stable hip that doesn't get infected and you don't get a blood clot and you don't get an MI, you just want a stable hip you can walk on. And that seems to do the trick for this patient group.
Yeah, I think it's incredible how unimportant the whole of the orthopedic aspects seem about offset. When Matt and I applied for that money, we wrote to the funder and said, essentially, we thought that the function would be much better if you got offset right and leg length correct, but it made no difference to the outcome.
And that was in a, you know, they were the patients who, this was at the height of total hip replacements. You know, in my practice, around 40% of patients were getting a total hip. So these were the patients selected for lower demand and hemiarthroplasty. So, I mean, we can't say definitively there wouldn't be a benefit of better hip biomechanics in the lower age group, high demand patients. But within the group that were randomized into the trial, then we couldn't find, you know, there was no hint of a difference in between the two interventions. We learned a lot from that trial. I learned a lot. A few mistakes I think we made in retrospect, but it's still pretty powerful evidence that actually in this group, you just need a stable platform you can get walking on immediately and get out of hospital quickly, and that's what you want, really.
Yes, indeed. So, Murty, are you happy with his answers?
Yeah, but I do think that there is some evidence to say that bipolar is as good as total hip. There is a randomized control trial from Amsterdam, Raymaker, which suggests that their patients did very well. In fact, they recommend that you shouldn't be using total hip if you're using a bipolar because the complication rate is high. And that trial is poo-pooed in our country, I know, in UK, but it is fairly good randomized control trial. But their scores were worse in the sense they used Harris-Hip scores rather than anything else.
Yeah, I think, well, as you know, there is other trials that suggest there's very little difference between bipolar and unipolar hemis. So I think we'll get a clear review. There's a Cochrane, Xavier Griffin and the team actually are just in the throes of finalising the latest Cochrane updates on the hip fracture data. So they pulled together all of the trials from all over the world ahead of the next NICE guidance. So I think it'll be really interesting to see what that Cochrane review comes up with about bipolars. I think it's still a question that's sort of probably unanswered, Murty. I tend to agree with you.
Okay. So, Matt, we've got one question from Sweden, from Francisca in Sweden, and she comments on the trial and how it mirrors the HOPE trial from Sweden. The question that's being asked is that was it further divided into the type of implant? So it's a similar sort of question to what we've been covering. You know, hemiarthroplasty, monoblock, modular, cemented or uncemented, and was that related to the revision by implant? I think I know the answer to this, but I'd be interested to know whether you know whether they did subdivide that.
So they've done some secondary analysis on the types of implant, but of course they weren't randomized comparisons. The surgeons used the implant they were most familiar with for the purpose of the trial, so it was quite pragmatic. So the only randomized comparison was total hip versus of your choosing versus hemiarthroplasty of your choosing. But they have done some secondary analysis, and I know I've not seen that in print yet actually, but I'm sure it'll be out fairly shortly, looking at the different types of implants and whether that makes a difference. Is that your understanding, Mike, as well?
Well, I actually didn't think they had done the sub-analysis, so you're one step ahead from me. And your view is that it didn't show a difference, but being non-randomized.
I can't remember the details. It's yeah, I may be breaching all kinds of confidences here, but yeah, I don't think it's in print yet, but I've certainly seen some of the data, and I'm sure Mo will be publishing on that because that is of interest. In terms of cemented, uncemented, I can tell you that there's another great big trial, similar size, that will report hopefully in the next 2 or 3 months. But unfortunately, I can't tell you what that is. Otherwise, I'll be shot. But yes, maybe another author hub meeting for that one. But there'll be some more powerful evidence to support that. And there's some interesting findings there. Actually, it's not as straightforward as you think.
Oh, that's very interesting. We're going to await that result then. It's a shame we couldn't tease it out of you. It would have been quite entertaining having NIHR on your back for breaching the results.
They've got spies everywhere. They just, yeah, I get sacked.
All right. Okay. That's great. Fantastic. So we've also got a question from David Milligan about dual mobility, but we are going to cover that a little bit later. So we're on it, David, and we will ask that question. So now we're going to move to Murty, who is a trauma surgeon in Northumberland, in the north of England. And Murty, do you want to share your screen?
Yeah, I'll do that. I cannot find my screen. What happened? Just hold on, guys. Advanced files, sorry, files. Oh. Cannot seem to be able to share my screen.
Should be at the top of the screen, I think.
No,
Normally
I can't see my file on the basic.
I wonder what we might do actually is just maybe if we can go to Sam initially to show your first case. Would that be okay, Sam?
Yep, I can do that.
Okay, we'll do that, Murty, and we're going to come back to you. So
I just need to make sure I can share my screen.
Yep. Okay.
I'm able to find yesterday it worked. Today it doesn't seem to work.
Yeah. Okay. So we'll have Sam up, Murty. That gives you plenty of time, and we're going to discuss this case from Sam, who is in sunny Portsmouth, but has been in work all day, so hasn't seen the sun.
And now it's grey outside. So evening, everybody. Thank you very much for inviting me onto this OrthoHub webinar. It's really nice to be invited back. I can't have done too badly on the first one. So yeah, I've been asked to present a case or a couple of cases. We'll start off with just one, sort of promoting the case for arthroplasty. And I am an arthroplasty surgeon. I do trauma, I do routine trauma, but my love is for arthroplasty rather than trauma. There's my disclosures. So the case I'm going to talk about is a 38-year-old lady, fit and well lady, no medical issues. She works as an operations manager and she's got 2 young boys at home. So I first met her in November 2020, but it all dates back sort of 6 weeks previously to mid-September 2020. So her history is that she fell off a chair, landing heavily on her right buttock. So that all sounds relatively minor, and why did she break her hip? But actually it's a little bit more complicated than that in terms of the trauma. So she had her right foot on a cushion that was on the floor. I'm not entirely sure why. And the cushion rapidly slipped on the floor, and so took her foot and her leg with her. And then she came down, crashing down quite heavily on her right buttock. So although it was from a relatively low height, it was with some force and some velocity. Following that incident, she was unable to wait there and she was in severe pain. But she sort of stoically carried on for the rest of the day, and then the next morning was still in a lot of discomfort, still couldn't wait there, so went to A&E. And she was seen and reassured that this was just a soft tissue injury, a bit of bruising, things would settle down, she'd get better. She was obviously struggling quite a lot because they did give her some crutches and sent her on her way. Things didn't really settle, and actually she represented to the minor injuries unit a few weeks later, where again she was seen, she was reassured that this was definitely a soft tissue injury, it would get better and she should just stop using her crutches. So she went back home again, things still didn't really settle, and her work were being incredibly supportive, but obviously she was struggling. And they said, well, what can we do to help? How can we help you? Who can we send you to see if we can, get a bit more information and get you better and get you back on your feet again? And I think she was obviously complaining of quite a lot of pain in her buttock, radiating all the way down her leg. So I think the assumption was that maybe this was sort of sciatic in nature. So she went off to see the local spine surgeon. He saw her and took a history, did a thorough examination and thought, this isn't back, this isn't coming from her back, this isn't sciatic, this leg doesn't look quite right, this hip certainly doesn't examine normally, I'll do some x-rays. So he did some x-rays. And this is what they showed. So we can see that she's got a displaced intracapsular right neck of femur fracture, and this is 5-6 weeks down the line. So that's the AP, and you can see that she's short. You know, she's contracted down, her offset is reduced, and she's externally rotated. And you can see on the lateral that the head's tilted off backwards. So, you know, this is certainly a displaced fracture. So he very kindly referred her up to the on-call service, and she was seen by the on-call team, and then I was made aware of her. Now, she was managing by this time to walk around, albeit with some difficulty on crutches. So actually she went home, and I saw her the next morning in clinic to make a plan and have a discussion with her. So when I saw her, she was weight bearing, but I mean, essentially she was barely weight bearing. She was loading all her weight through her good left leg and really not using much not putting much through the right leg at all. She was short on that leg. She developed some fixed flexion, and she certainly had some external rotation. And when you examined her on the couch, the hip was really irritable, very painful. She couldn't straight leg raise, and she's just really struggling. So what are our options? Well, there's always the option of conservative. I don't really think it's an option here at all. She was really struggling. You know, we were 5-6 weeks down the line. Things weren't going to get better. The hip wasn't going to get normal again. We absolutely have to do something with this young lady. So what about fixing it? Well, the trauma surgeons would probably argue for that case, or certainly put a stronger argument for that than I would. My thoughts on the fixing were she's 5-6 weeks down the line. What are the chances of getting this reduced to a good anatomical position, back to where it should be, so that your fixation holds and it heals, and she gets back to having a normal hip with normal leg length and normal position of that hip, that she has good long-term function? And I think that's going to be a really difficult operation. You're going to have to open it. Everything's going to be short and contracted down. That's going to be a big, difficult operation, and certainly not one that I think I have the skill set to do, particularly at that point post injury. My other concern is she's 6 weeks down the line. Is that head even alive? You know, what's the blood supply to that head? Has it been compromised? Does it still have a blood supply? Even if you can get your x-rays looking beautiful and it fixed beautifully, is that head going to survive? And are we in 6 months' time going to be in a situation where actually she's got avascular necrosis, everything is collapsing down, she's got non-union, and actually we're then looking at her needing a hip replacement anyway, but then it's a slightly more complicated hip replacement because you've got the metal work in, so that needs to come out, and all the slightly increased risks associated with removal of metalwork and then a hip replacement, such as a slightly increased risk of infection. And in the meantime, she's had another 6 months of potentially not putting her full weight through it, things getting gradually more painful, more disability, and she's still not got her life back. So I had a good long chat with her. She was a very sensible young lady, and actually we discussed all the options, and we certainly discussed replacement. And my feeling was that actually she just wanted to get better. She wanted the pain to go. She wanted to be able to walk around. She wanted to get back to work. And really importantly, she wanted to be able to play with her young family and enjoy her young family and get on with her life. And she just couldn't do that. And she didn't want any uncertainty of how quickly that could happen, or whether that would be delayed if we did something different. So she was absolutely certain that she wanted a hip replacement. And so I got her in a few days later, and we performed that hip replacement. So the question is, you're all going to say, but she's only 38, you can't do a hip replacement, it'll need revising, that's a difficult thing. But actually, this is about quality of life. And we all know that hip replacements give a fantastic improvement in quality of life, and actually have a really good long-term survivorship. So I haven't gone through a lot of data. I'm not a great researcher. I'm not a really clever person like the rest of the panel are. I'm just a jobbing hip surgeon who likes to think I can do quite a nice hip replacement and give people pain relief and a good quality of life. But I just put this slide up. So there was a study a couple of years ago in the Lancet from Jonathan Evans and the Bristol group, where they did a meta-analysis of a fairly large number of series of hip replacements, and also looked at a big amount of registry data. And they did some clever fancy stats on it, and essentially showed that if you looked at the series of hip replacements, that a hip replacement could be expected to last up to 25 years in 77.6% of patients. If you looked at the registry data, it was a little bit more conservative at 57.9% would last 25 years. So with their analysis, what they concluded was that actually surgeons can expect a total hip replacement to last 25 years in 58% of patients. And that was based partly also on them essentially saying that registry data is much less likely to be subject to bias than the data presented in the case series. So it's much more likely to be sort of accurate in terms of survivorship. So 58%, 25 years, that's good long-term survivorship, but I can hear you all saying, but that's 42% that won't last 25 years. That's 42% that will have had an earlier revision. And that's absolutely true. But we know hip replacements give you a good quality of life and have good survivorship. And I think, you can absolutely justify doing that. I think the other thing to say was this was arthritis data, but actually, if you look at this graph from the National Joint Registry, what you can see with the blue one being the fractured neck of femur data and the purple being the arthritis data, you can see that actually by the time you get to 16 years, the revision rate actually is no difference. And actually the increased revision rate for the fractured neck of femurs all happens in the first year. So that's all those early complications. And there probably a lot of that is early dislocations, because we know they do have a higher risk of dislocation. So actually, I think you can justify doing a total hip replacement on a young patient. So just to remind you, this was her x-ray. So I'm a hip surgeon. I've had it drummed into me that you have to plan. So I did some pre-operative planning. And you can see from my red writing at the top that I thought she was just over 2 centimeters short. Interestingly, when you asked her, she didn't really perceive that she was short. And I think that was partly because she was just loading so much on the left leg and offloading the right leg and she was so leant over that she hadn't really been able to pick up on the actual shortening of the limb. So anyway, I did my templating and then executed the hip replacement. I think if we're going to critique, you could say my offset is not quite perfect, but she actually has done incredibly well, and she's been able to get back on with her life, and she's doing well. So that is my first case.
Okay, Sam. So thank you very much. Very, very clearly presented. So I suppose if I'm playing devil's advocate, I'd say, right, well, so she's 38. So I wonder how relevant the Lancet paper is when you say, well, 58% to 25 years, because well, as you know, it does relate to age, how long the implant lasts for. So tell us what measures you took in your choice of implants to give us some longevity.
Well, as you said, I did a hybrid hip. I'm a cementer, so all my patients get a cemented, polished tapered stem, whatever their age. And I think the registry data absolutely supports that. We know that those stems perform extremely well in all age groups. I'm also a fan of the cemented cup, and the vast majority of my arthroplasty practice for arthritis is a cemented cup. But I have to say, in the younger age group, I do tend to use a hybrid cup, and I think again the registry data supports hybrid fixation, and I think the cumulative revision rates for hybrids and for cemented hip replacements are very, very similar, and I think there's not much in it. I think it gives you slightly different bearing options in the sense that if they've got a small hip, you can get to a 32 head a bit more easily than in a cemented socket. Sometimes you have to get up to a slightly bigger size before you can put a 32 head on. And if you haven't got that option on the shelf, then perhaps that slightly puts up your risk of dislocation. So that's my rationale. And thinking of the revision down the line, we know those cemented polished tapered stems have fantastic survivorship. So actually you're not concerned that that's going to fail. That's certainly not my concern. But if you do need to go in and do a socket revision because there's some polyethylene wear and they've got some lysis behind the cup and you're concerned that the cup's starting to loosen, or she's getting a bit of eccentric wear and perhaps some sort of episode of subluxation, it needs revising, actually that socket revision is easy, and you can easily tap the stem out of the cement mantle or move it out of the way, and do a very easy in cement revision. So actually, even if that young lady needs a revision in 20 years' time, it's an easy, straightforward revision. So that's my rationale for my implant choice.
Okay, and you may have said, but was it highly cross-linked poly that you used?
Yes. And I think my other rationale is that using a cemented polished tapered stem and my preoperative planning, I can absolutely, to the best of my ability, restore her offset and leg length and give her a good hip that is going to function well, because that's what works well in my hands. And you can independently, change your leg length with that cemented polished tapered stem, so you can get that right. So you can get her back out to length and make her happy. Okay,
perfect. So Murty, you would have fixed that, right?
I think yes. I mean, I would have erred towards fixing it, and it's consent process. Okay, what we have to talk about is it's not what I want to do. You have to present the patients with all the options, and my rationale for fixing this is that I don't have to open it, and it sounds rather pompous to say that I can, in most cases, reduce it closed. And when I do my presentation, if I can get it up, hopefully I'll show you how I do it using various wires from outside without opening the fracture, how I reduce it, and how I can get it to reduce reduction. And there is a reduction called the stable reduction, where the proximal of the distal fragment has to key in distally. It has to be distal when you reduce it. And can I show this? So if this is the neck of the shaft, if the neck of the distal fragment, that is a shaft, neck attached to the shaft, it has to be distal to this, so that when you reduce it, it is a stable reduction. And there is no evidence for it, but that's what I cause. I get a stable reduction and I get a fixation, and I get a fixation in such a way that it does not collapse anymore. And my rationale is that, and I can get them weight bearing straight away. If I use a DHS with a cannulated screw, I can get them weight bearing straight away. They walk, they do not develop a flexion deformity of the hip, which is a problem with non-weight bearing for more than 6 weeks, or if you let them non-weight them for 3 months. And if it fails, and the failure rate is only 30%, we must remember, it is 30 to 40%. Even the avian is about 10% and about 30% failure rate, but 60% of these do go on to heal. But the problem is foreshortening. The offset goes down. They don't have an offset. And if these are the people who are painful, then doing a total hip replacement at 6 months, 1 year has much lower risk of complications than doing immediately in a fracture. Now, I know Sam would have done it because they're 6 weeks old and it's got capsular adhesions and tightening, so the risk of dislocation is low, but still the risk of dislocation in a trauma scenario is higher than in an elective scenario, or the risk of infection is higher. So complication risks in a total hip are higher in fracture fixation, in cases of fracture, than in elective cases. That is my rationale for fixing it. But in the end, you have to give all this choice to the patient. And the patient decides, look, if I fix it, there is about a 30, 40% chance that in 6 months to 1 year's time, you'll have a total hip replacement. It won't be that difficult to total hip replacement, but slightly more difficult than a standard total hip replacement. But the risk of dislocation and infection are lower, is what I would say. Whereas if I fix it, there is a small chance you'll get away with it for another 10 years, and then you will need a total hip replacement.
All right, thank you, Murty. I love all this stuff. It makes no sense to me.
I couldn't show the picture. I drew the picture for you this morning, didn't I?
You did.
You did exactly that.
I'm so pleased you're not my trainer. But
Murty's just demonstrated exactly why fixing these things closed is a disaster, because look, it looks really well reduced.
So
you're telling me you deliberately overlap them, Murty? I mean, I spend a lot of time trying to reduce them anatomically, but and I sometimes miss, but I don't deliberately overlap them.
No, I will tell you, Matt, you need two views though. When you do fix them, we get an AP view and a lateral view. And then we also use something called Gordon's index. So you need to make sure that they are parallel. And if you fix, we are arguing a bit. Yeah, yes, fixation, but in a way that it remains stable. You should not produce shear forces across the fracture site. And at one of these days, I should be able to explain to you why having it slightly lengthened does not cause shear forces rather than having it slightly short.
Okay. Just one. Sorry, Mike. Just one point on the evidence base. I mean, our colleagues from Scandinavia on the call will know this literature better than me, but there is quite a bit of evidence, to my understanding, that if you delay the total hip replacement, their overall end function is worse. So a delayed salvage total hip replacement ends up with a worse result than a primary at the beginning. So I think that is an important point. And just on the 30% failure of fixation rate, not at 6 weeks, it isn't. I think that's a lot higher if you're presenting at 6 weeks, as Sam said. So yes, for acute fractures, you'll get away with them 60, 70% of the time if you reduce them anatomically and fix them stably. But at 6 weeks, I think the chances you're getting an anatomic reduction at all are slim, and getting that to heal in that position, I think is very unlikely. So they'd be my only comments. And I'll stop giving Murty a hard time now. Well, at least for a little while.
Yeah. Yeah, I wouldn't stop just yet.
And I was nice to you.
It's all relative.
Fair enough. Okay. But
So
I've
here's
learned a lesson now.
I've got a related question from one of the attendees. Who's this is a very good question. It's from an anonymous attendee, but I think it does reflect real life actually. So they say they're not a hip surgeon, but they do manage undisplaced fractures of the neck of femur. And during a trial of fixation, the fracture then displaces when you're essentially partway through the operation. What should you do in that situation? And I think that does happen. It's the first time I've heard it discussed, but I think it is a real problem. So I don't know. Would one of you like to answer that, or I can choose somebody?
I'm happy to say what I do, Mike. But whether it's the problem is when we're talking about young people with displaced intercapsular fractures, then. So I work in a major trauma centre. I've got a vague interest in these things, but I see 2 a year maybe. So the truth of the matter is, none of us have massive experience in this area. It's not like Sam knocking out hundreds and hundreds of total hip replacements a year who can talk with confidence about what she does and why she does it reproducibly. This is something that's esoteric at the best of times. So I tend not to be didactic with it. I will attempt a close reduction, as Murty would do. I have a very low threshold for going for an open reduction for these younger people, so I can see the neck and actually make sure it's at least as anatomically as I can get it reduced, and then fix it in place. And if I can't get a stable fixation, I will convert to a total hip on the table to answer the question, because the worst scenario is an unstable fixation for the patient. And as Murty pointed out, this is all about your discussion you have with the patient beforehand, when the truth of the matter is there's no right answers here. None of us know what the answers are. So you present the options to the patient and warn them that I might change my mind during the operation. You might wake up with a total hip replacement. So anyway, that's my approach, but whether that's the truth or not is a different matter.
Yeah, no, good. Thank you very much.
So can I ask a question to Matt? Matt, you talk about open reduction. So this patient is on a fracture table, and you have put it on a traction table. You have opened laterally, and you're trying to put a guide wire in. You found that the fracture is displaced. Would you take those of us who are not familiar with the open reduction technique? How would you then approach it?
So I don't use a traction table for these younger patients, Murty. I do them in a lateral for a total hip replacement type position, slightly sloppy lateral. And I've tried using a lateral approach for your fixation insertion and using a direct anterior approach to do the reduction, and I can't see very much down those holes. So I've taken to just using a standard anterolateral approach, doing a incision in the capsule to see the neck, and then repairing the capsule afterwards. So that's how I do them, and I put the DHS or whatever fixation tool I'm using in, in a lateral position, which once you got used to using lateral position nailing, actually working out, it's just getting your head around the angles the first few times, but actually it's a very easy thing to do, is to put the fixation in from the patient in a lateral position. And also, of course, then it's really easy for me to convert to a total on the table without moving the patient if I need to. So that's my approach. But crikey, you speak to 20 different surgeons, you'll get 22 different answers. That, you know, there is no, I think it's important for everyone on this call to realise that this isn't a hard evidence situation. This is my anecdote. This is my thought this week. So that's how I approach them. And
Well,
one or two of my colleagues do a similar thing as well.
Well, yeah, I mean, that's been my issues. I do all of mine on a fracture table, because I can then internal rotate, get the trochanter and get that antiversion right and everything right and get it reduced. And then I can put a DHS or a cannulated screws very easily through a small incision, and it's a low, small incision procedure. And then when I try to do the open reduction and I have to elevate the capsule from the front, I find that watching that, seeing that reduction, that neck to reduce it open, is well next to impossible as for in my incapable hands. So I find it much more easy to joystick the head and the shaft and reduce them using various techniques. So I almost always use closed reduction techniques. I have not done an open reduction for 20, 25 years now. Probably did one in the first year of my training when I was working with a pediatric orthopedic surgeon who was very used to this. Doing an anterior capsulotomy.
It is. I do the open reduction. You can see everything anteriorly, but of course, often in these cases, the comminution of the neck is posterior. So you can get a beautiful anatomic reduction anteriorly, but don't kid yourself. You've got good bone contact posteriorly. That's where usually the pieces get spat out backwards and are floating around. So yeah, and the other advantage is you can remove any debris from the hip if you're doing an open approach, but that's a small advantage, I would say. The main thing is to try and get an anatomic reduction. So, I mean, the last time I did this was a couple of months back, and I was actually in a child, but so it's slightly different matter again, but I had to do an open reduction just to make sure I got that anatomic, and we fixed it in place with a sliding hip screw, actually, with a short barrel. But it's, yeah, as I say, we're drifting into hardcore anecdote now.
Fantastic, fantastic discussion. Actually, I'm learning so much this evening. So, I'm going to go to Murty now. Are we up for sharing screens?
I'm going to try again. Yeah.
Okay, if you can just talk us through your couple of cases.
It's not letting me. Why can't I see my files? Sorry, guys. No.
That's okay. Talk us through what you can see. We're going to have one of those. I
can't open my file. Just give me 1 minute and let me see if I can. I can't do anything right now. Wait a minute. Can I reduce this? And let us see if you can see this.
Don't worry, we can get the Author Hub team to cut this bit out.
Okay, can you see this? Can you see my screen?
Not yet.
Mike, Ramon was just suggesting you might want to talk about dual mobility while Murty's loading up.
Yes, okay, that is a really good suggestion. So, we've seen in Sam's presentation about the complications of hip replacement for trauma, and they tend to occur in the first year. Beyond that, they're really mirroring the revision rates of osteoarthritis hip replacements. So one potential solution, and David Milligan has raised this, is should we be using dual mobility hip replacements? And I think this is a really important question to explore, and I've got some views on it, but I wonder whether, Matt, are you willing to give a view on whether we should be using dual mobility in this group?
So I can give an opinion, Mike. So we did a small trial a little while back, a pilot study, trying to randomize patients having a total hip for trauma to dual mobility or not. And at that stage, we couldn't run the study. We couldn't get enough patients through. And particularly couldn't get enough surgeons who were happy and familiar with both techniques to randomize patients. So we only had 20 patients so in the pilot. Since then, there are studies that have been bigger, and some of those are ongoing. So I think there will be some evidence in this area. Empirically, it makes sense because, my understanding of the literature is, and Sam will tell me if I'm wrong here, that the dual mobility is more stable, the dislocation rate across the board is lower. So if your main concern in the first year after a total hip for trauma is dislocation, which the health study and others would suggest it probably is the main cause of revision surgery, then a dual mobility makes sense. You've got to balance that, of course, against the added cost and against the relatively unknown long-term outcomes of that implant, and particularly in this patient group.
Yeah, I mean, I think what worries me, we'll talk about the results in a sec, but what worries me is getting these things out if you get an infection. That you've got essentially a metal liner cemented in place, certainly if you're using a cemented dual mobility, and getting that out in the context of an infection in one of these patients would be a nightmare. So that's what worries me even when I'm doing it. Sam, what do you think about dual mobility in this context?
I think dual mobilities have a role. I think if you're doing a total hip replacement for trauma, we absolutely know that your risk of dislocation is higher. But I think, as Matt says, that actually there's a little bit of an unknown about survivorship, long-term follow-up of these implants. My argument would be, and I don't routinely use dual mobilities for hip fracture trauma, because actually I think if your patient is good enough to have a hip replacement, if they're high functioning enough to have a hip replacement, then they should have what you would normally do for your hip replacements. So I don't consider that slightly increased risk of dislocation warrants giving them a slightly unknown implant. I think what I would do is, rather than just allowing them to have standard hip care, I asked the physios to talk to them a little bit more about hip precautions. So just rein them back a little bit more than you would with your normal primary arthroplasty hip. But I think if they're good enough for a hip replacement, they're good enough for a standard hip replacement with, in my practice, generally a cemented polyethylene socket.
Yep. Okay. Fair enough. So in last year's National Joint Registry report, we did actually split up the hip replacements for trauma into two groups. One was the unipolar, which is the standard hip replacement, if you like, and the second was dual mobility. And we've plotted their survival from day zero, if you like. And what we found actually is that it doesn't affect revision rate in the short term. So despite the fact that they are likely to sort out dislocation as an issue, it doesn't affect the revision rate. And the revision rate in the early few years of unipolar and the dual mobilities is really identical in the National Joint Registry if it's done for trauma. What I would say is that as in the latter few years of follow-up, the revision rate appears to increase in the dual mobility group. So although it's tempting to do these to reduce dislocation rate, it doesn't actually appear to make a difference to your revision rate using dual mobility. So we have got Murty, and thanks very much for sorting that out, Murty. I'm delighted that you've got your computer driving test sorted. And
wow. So there you go. There you go. So I keep talking about keeping your head, and I couldn't keep my head when I was doing this.
Yeah, no, that's fine. So we're slightly a little short of time. So if you could run through relatively quickly, that would be awesome.
Fantastic. Well, before I start, can I say that I was so proud that I was sharing the podium with all of you guys, including you, Sam, and Matt, that I sacrificed my mustache that's on the photograph. Anyway, so some dull bits. By 2050, we will have 6.26 million hip fractures per year. And we should all become good at dealing with this. There is absolutely no doubt about it. And for the arthroplasty surgeons here, I have to just remind them that hip fractures are extracapsular or intracapsular. And as Matt said, there are people elderly people with significant comorbidities. And then there are these difficult ones called the subtrochanteric fractures and the complex hip fractures. And today I will try and talk about each one of them. Now, this is an extracapsular fracture in an 80-year-old gentleman who's not entirely fit, but can walk about at his home. Is there anyone in the audience who would do a total hip replacement on this, or after Matt's talk, a hemiarthroplasty on this? That's fantastic. No one in the audience wants to do that. That's correct. You shouldn't do a total hip replacement on it. You should do the simple device called the dynamic hip screw, which just put it in the middle of the head, connect it with 3, 4, 5 screws, whichever you prefer, and the patient does well. And this patient had one on the opposite side. We gave him an exact copy of that on the left side, and he was weight bearing from day one. And we got him home on the next 4 to 5 days. That's it. Now, slightly more complex, this one. This one has got a separate trochanteric fragment and a separate lesser trochanter fragment, and slightly lower than the last one. Would you bin this head? Anybody in the audience? Or still try and fix it? Like I said, I am a fixer, and I would go and fix this. And this is what we did. We did a DHS on this patient too. And she went home, she quartered on it for about 3 years. She's 90, and she was so unhappy that we didn't do a total hip replacement or a hemiarthroplasty on her. She came back 3 years later with an intracapsular neck of femur, for which we ended up doing a hemiarthroplasty. Now, these are more complex. That is the extracapsular fracture neck of femur. These are subtrochanteric fracture. And what would you do in this? I mean, you could treat it with a total hip replacement, but God, that will be a very difficult total hip replacement where you have to cut it here, put the stem in, trochanter has to be attached back. Instead, all you do is put a big round metal thing, put a screw on the head, and this tends to do well. And that's him 2 to 3 years later, slightly medialized and slightly protruding hip, but he is fully weight bearing. He came to us with a pain in the left hip. What do you do with this? This is a broken nail, a subtrochanteric fracture that was fixed with an IM nail. And then she came to me about 6 months later with a painful hip and was referred to me with this. Would you then consider, she's 64 years old, she was an ex-social worker, smokes about 16 cigarettes a day, but otherwise an independent, lives at home. I don't do total hips in this. What I do is fix them. And what I have found is that this device, the Synthes hook plate, helps me restore the offset and the neck valgus very well. And then once I've fixed it, got the neck valgus and got it reduced, I can then slide a nail and use this as an additional fixation to make sure the trochanter is reduced on and stays on. And I've got a series of these nail plates which seem to work well. And most of them heal, and they are fully weight bearing from day one. And that's 6 months later. So in about 50% of the fractures are either extracapsular or subtrochanteric according to a natural hip fracture database. And in those, binning the head is not an option. You must preserve the head. And for extracapsular fractures, I think there is only one device that we should be using. That's a DHS. And for subtrochanteric fracture, it's a nail. So there you go. In 50% of the hip fractures, you should not do an arthroplasty. Let's come to intracapsular fracture neck of femur. This is a 52-year-old lady with a minimally displaced intracapsular fracture neck of femur. The options here are either to do a total hip replacement, or if you believe Mo Bhandari's paper, a hemiarthroplasty, or in my book, I would do this. You put a DHS, you put a cannulated screw to ensure that it does not rotate. It's a derotation screw. They weight bear from day one. And that's the lateral view. And that's the X-ray at about 3 years. This lady was referred by her GP, but she was limping, but she also has got back pain. And this is what went to an arthroplasty surgeon, and he said, this lady doesn't really report any pain from her hip, and he discharged her. So in undisplaced fractures, which is definitely a certain percentage of intracapsular fracture neck of femurs, whether they are young or old, I think it is reasonable to fix them. In older people, there is a trial from Peterborough which suggests that if you fix them, the mortality rate is lower. So in very old, very frail people, I think this does have a role to play. So there you go. Now, something like this really tests you, or at least tested me. I'm sure some of you will find it very easy to do. So this is a lady who has osteogenesis imperfecta. She's 60 years old, and she presented to our trauma unit with this fracture, an intracapsular fracture neck of femur with a bent femur below it and a knee replacement put in below that. And these are the other views. Now, what are the options? So the issues in this case are, one, the neck fracture is vertical orientation of the intracapsular fracture. Not only is the fracture intracapsular, the orientation of the fracture is vertical. There is a varus malunion of the femur. The canal is narrow. And there's a knee replacement stem that stops us putting anything into the medullary cavity. And she has osteogenesis imperfecta. I will wait for the panel to tell me, but I have not seen a non-union in a patient with osteogenesis imperfecta yet. They get fractures, but they tend to all heal for some reason. So what are the options? Should we fix it? Should we replace it? Or we should do osteotomies along with fixation or replacement? So this patient actually was discussed with our arthroplasty team, and one of my colleagues is one of the nicest arthroplasty surgeons I've seen, apart from Mike Reed, who put it kindly on the World Twitter Forum of the hip surgeons. And the universal answer was to do a total hip replacement. So what he did was to template it. He put a smallest exeter, and smallest exeter was ending just below where the deformity started. And he could not put an arco stem because it was too long and it would impinge on the stem of the femoral component of the tibia. And then by then I was involved, and just because everybody was saying we should do an arthroplasty, I decided we should fix it. But apart from that, there were these issues that if you did an exeter, there was a stress razor below, so you would have to do an osteotomy and plate it. The shortest arco stem wouldn't go in. So I thought I should fix it. And this is what I do. So I put the patient on a fracture table, and I put a joystick into the head. And I manipulate it so that the position of the head, as far as I'm concerned, is perfect in the acetabulum. Then I reduce the shaft to it. And I use a guide wire, and I sometimes use an added guide wire to fix it to the acetabulum. I know children should not, younger trainees should not be doing it, but I'm very careful when you do it so I can get away with it. Then I put the screw in, and it was distracted. And as soon as I saw that, I chose a smaller screw and put the screw in, and then used a compression device to compress it. And that compressed the fracture back to where it was. And once you've done that, I put a 2-hole DHS and did an osteotomy below the 2-hole DHS. And then what you do is you change this screw plate to a longer DHS and make sure that goes well beyond the stem of the femoral component of the tibia so that there is no stress razor. And to give it stability from front to back, I put an anterior plate. At the end of this case, I thought that we had used a lot of suction because that was the water was, but actually it was me who was pissing in my pants. And then this is her 6 months later. The medial side just take a while to fill up. That hasn't filled up, but everything else has healed. And she now wants me to fix the opposite side. So there is absolutely no doubt about the fact that arthroplasty is the holy grail. And I'm surprised as to why arthroplasty itself hasn't yet been given a Nobel Prize. It has changed the life of millions of people, but it is still has risks with it. There is a risk of dislocation, there is a risk of infection, there is periprosthetic fractures and wear, and it is a big physiological insult to the patient. Till we can do it through an MIS, until the arthroplasty becomes longest lasting without any risk of dislocation and infection, I think we should keep screwing. Sorry, I meant keep doing DHS and nailing. Thank you.
Murty, thank you very, very much for that. That was a truly amazing case, that last one you showed. And how you have the vision of working that through in advance is just so impressive. I wonder whether we could discuss the nail plate scenario though a little. I don't know. I might just ask Matt what he thinks because he doesn't mind giving you a battering, and then maybe we'll ask you to justify how that works physiologically.
It's a great case, Murty. Yeah, and I you know, there were definite problems with doing a total hip replacement there, so I wouldn't disagree with your approach at all there. I'll be delighted to see next year when you present the pictures with the union of the femoral osteotomy site. So being cynical, yeah, I think so. I would tend to go extra medullary here as well for two reasons, both of which Murty alluded to. One is that actually reducing the fractures is easier in my hands with an extramedullary device, and secondly, you've got to overlap with that stem in the distal femur, otherwise you will get a fracture between the two. So for both those reasons, I would use an extramedullary device in this case. The other option here, I mean, Murty put so much metal work in, you might as well have done a total femoral replacement, really. You'd probably be lighter for the patient afterwards, but that's the other option, I guess, here. But obviously that's a different skill set and so on. But no, very impressive, Murty, in all seriousness. That's a very cool case.
You know, I must come back to say as to why I did what I did. So my rationale was that one of them, if healed, if one of either the osteotomy or the neck healed, a non-union of an osteotomy is not difficult to treat. I treat them regularly because I do a lot of osteotomies. I get non-unions of fractures and I can get them to heal. Sorry, it sounds pompous, but you can get them to heal. There are ways of getting it to heal, especially in case of femur. In absence of an arthroplasty above and below it, even in presence of infection, you can get them to heal. So non-union of an osteotomy was not a problem. And the non-union of neck with a united osteotomy, and again, is not a problem. You can do a total hip replacement. And I would send it to my colleagues who would do very good total hip replacement on them. That includes Mike. So my rationale was all I had to do was to get one of them united. And my experience with fixing neck fractures is it is almost entirely stability and alignment, almost entirely. If you can make it stable and you can get that neck shaft angle right, they heal. That's what I did in this case. I made it stable by using a DHS big screw and a small screw. And I got the neck shaft angle right by using a 135-degree plate and doing an osteotomy. And the other thing that was in the back of my mind was osteogenesis imperfecta patients tend to heal. I do not know the rationale for it. It's purely anecdotal, and we were into anecdotes before. And that's why I did that. I knew that total hip replacement was, and one of my ex-bosses used to ask me, before you do an operation, always think, what is the next operation you're going to do? Do not burn the bridges for the next operation. So that's always there in the back of my mind. If I fixed it, and if it failed, there was always an option of a total hip replacement, which is why I did what I did. And I must say I got away with it. I'm not very bothered about the osteotomy, the medial side osteotomy. It is an opening wedge osteotomy. And because it's a spiral osteotomy, it opens up a bit. That takes a long time to heal. But because everything else is healed, otherwise the screws start breaking. At 6 to 9 months, one of the screws at least breaks if your osteotomy is not healed. So none of the screws are broken, and the patient is pain-free, fully weight-bearing. I am absolutely sure that's healed. And I will bet my bottom dollar on it. Sorry.
Murty, just let me ask you a separate question about the nail plate case.
Yeah.
What's the philosophy there? Because you're essentially making it presumably very, very rigid. And
Yeah.
When I was a lad, that was considered to be a bad thing. But I mean, I know they're healing because I see them in your practice. But just explain the philosophy to us,
So,
if you would.
So two things. I mean, one of the things in proximal femoral fractures, the problem that we have is that flexion and abduction of the proximal fragment. So whether you use a nail, but if you use a nail, that the size of the nail's proximal end of the nail, and there is a biomechanical study which shows that the diameter of the proximal diameter of the nail is this one of the bigger predictors of the stability of that construct. But the nail sizes we have, it does not control that flexion. And I have seen this multiple times. You hold a clamp around the trochanter, and as soon as you remove it, even when you're fixed it proximal and distally, the proximal fragment goes into flexion and abduction. And that is a killer as far as subtrochanter fractures are concerned, as far as I'm concerned. So to control that, you use a plate just to hold it together. It acts as a tension band. And as long as you keep the soft tissue envelope, the more stable you make the construct, I think bigger are the chances of healing. And now the AO is now, Bob Handley presented this talk in BOA. In fact, about 5 to 6 years ago, we were both in a Barcelona meeting, and he talked about this, what is strain modulation, where he puts interfragmentary screws in non-unions of spiral fractures of the femurs or the tibia. And he said strain modulation. That is rigidity causing an increased rigidity in a load-sharing device. And this is just one step more than that. And if I am doing a nail in a subtrochanteric fracture, which is spiral, in fresh cases, new cases, then I use interfragmentary screws around the nail to keep the fragment from flexing and abducting. And so the more stable the construct is, and also when you listen to these AO trauma surgeons talking about locking plates from Austria, they will talk about what is called a fracture screw. They put interfragmentary screws, and because AO frowns upon interfragmentary screws with locking plate, they talk about fracture screws. So increasing the stability without losing the soft tissue envelope and the soft tissue, the blood supply to the fracture is good. And that has been shown in 35 cases of these nail plates that I've done, that most of them heal. There are a few failures, and that go to you, no doubt. There are 2 or 3 failures, but generally they are successful, and they can weight bear immediately. They are a very stable construct. And the trochanteric plate does not seem to bother people. And that's why I get weight-bearing x-rays at about 1 year to see whether there is pelvic tilt on the opposite side when they are single leg weight-bearing. If you get a weight-bearing pelvic fuse and they are single leg weight-bearing on the effect side, the opposite pelvis does not tilt down. It means the abductor mechanism is working well.
Okay.
And there is no Trendelenburg weight. So I look at that, and if that is a problem, then I take the plate out. But I haven't seen it yet. Most of these people, again, are slightly older group. And I've got one patient whom I operated upon about 6 times, not because each one has failed, because he's broken above or below it. Each time I take the plate out and he breaks below that plate, and I go and refix it. And then he goes on a motorbike and breaks it again. He came back from Wales because he didn't want it operated there, because he had broken just below the supracondylar. I had put a whole long nail, and he had fallen just below the nail, so I had to do the refixation. So
Murty,
they do tend to work.
Yeah. Sorry, Murty, we need to leave it there. But just the couple of the the audience have made the point, which I'm not going to let you come back on, but I know you'll probably concede, is the work that's been done on the worst outcome if they've had a fixation before and then you need to go on and do a hip replacement. And Kailash has made that point, and Francisco sent a reference through from BJJ about it. So secondary THR, if you need to do it, is not as good as primary, and I'm sure you'll concede that.
Yeah.
I think we probably need to call it in. I think that's been a fantastic actual debate and generalized teasing of each other about our various practices. I've definitely learned a lot. I'm very grateful for Raman and also from the whole Ortho Hub team for inviting us to come and talk about total hip replacement for trauma and also some of the alternatives. Particular thanks then to our faculty this evening, our three expert faculty, so Matt Costa, to Sam Hook, and also to Murty for their fantastic talks, debate, and insights. I'd like to advertise to you the British Hip Society's meeting next week if you have an interest in this topic, and I'm sure everyone that's listening in does. And you can tune in also to the next Ortho Hub webinar. So thanks very much, everybody. We will leave you alone, and good night. Enjoy the rest of the daylight if you have any in your country, and we'll see you soon. Good night.
Thanks, Mike.
Thanks, everyone.
Thank you. Thanks, everybody. Bye.
Bye.